and menopause. And I think because we live in this world of all things midlife and menopause, that we're like, oh, everybody knows this. Everybody's heard this. But the reality is they haven't.
It's the truth. And I was actually, as I was getting ready this morning, I was chatting with my mom, and she was saying, oh, I should have your sisters listen because they're 10 years younger and they're in perimenopause. And, I feel like we talk about this all the time, but the truth is women still aren't hearing us.
I know.
There's so much that needs to be shared. And we are here to share it. And I'm just trying to, Lizzie, talk about menopause for a sec. I'm just trying to do some technical stuff. Talk about something else. I'm in charge of the tech, guys. It's kind of like I'm, tapping my head and rubbing my stomach at the same time. So I'm just bringing in our doctor. But as I'm doing that, Lizzie, why don't you just explain some of your menopause stuff that you've been going through?
Oh, some of my menopause stuff. Well, I am postmenopausal right now. But when I was going through perimenopausal, I just felt like I was getting every symptom under the sun. And, people joke about brain fog a lot of times, but it really scared me because it was just like little basic words that I would forget, or I'd be talking and then I'd completely lose my train of thought. And as a, former broadcast journalist, I thrive off of what I can keep up here and just speak extemporaneously really quick. And it still happens now where all of a sudden I'll be like, what is that word? What is that word? Oh, it was cake. And it's just a really basic word. But the brain fog, I really thought that there was something wrong with me. I didn't realize that that was a symptom of perimenopause. And that really, really scared me. I know I also had, I have high blood pressure and have been on medication for that forever. But then I started having these weird heart palpitations that, made me nervous as well. And so that was another thing. The losing my hair. I mean, that nobody ever spoke about, and then going to brush your hair every morning or take a shower. And, when you go in for the big shower and you do the deep condition and then you get out, and I would brush my hair and I would just have clumps of hair. I'd wake up in the morning and on my pillowcase, there'd just be like all this hair, so those were things I was like, and then the adult acne. I was like, I've never had to deal with that before. And suddenly I was getting this horrible hormonal acne on my chin. And then I was like, this is abnormal. I'm going to the doctor. And that was
I had that happen too.
I had that horrible acne. I was actually on birth control pills because I've got endometriosis. And my doctor had said it was around 45, 46. She said you could go off the pill. I didn't need to be taking anymore, but I did that. And then, oh my God, then I was experiencing all those perimenopause symptoms like you explained. And I was breaking out all over the place. I was like, we already did acne.
Right.
Why is this happening now? Like, why is this happening now as an adult? And all that weird stuff. And then just the emotional fluctuations. And I actually went back on the pill because it was too much for me. And then I went off the pill at 50 and then never had a period again. And now I'm having my different things. That wild emotional roller coaster has ended, but the brain fog, that is real.
And those horrible periods where you're just like, the floodgates open up and you're like, I haven't had periods like this since I was in high school. Like, I didn't even want to leave the house. I was like, I don't have enough pads in here to deal with this much. It was insane.
People have talked about that. They call it something, I can't remember what it is. Somebody had a really funny term for that. I had the same thing where you couldn't even plan because it was a period 3 weeks, it was 5 weeks, it was 2 months. So you couldn't plan. You're like, I wasn't planning on this. And I did have an incident with some cream pants, and we'll just leave it at that. We'll just leave it at that. Dr. Culver, you are on their request to join.
See that she has requested to join us.
I haven't seen that yet. Request
Oh,
to join. So
I can see it on my end that she's requested to join.
I think somebody in there is saying request to join if needed. Let's see.
Oh,
here.
I see.
Okay, let me see. Okay, there we go. It popped up finally. So here we go. 3 menopausal women can do an Instagram live.
We can.
We can. There she is. Hi, Dr. Culver. We got you on. How are you? Thanks for joining us today.
How are you?
So we were just riffing on our own little menopause journey, but we're going to get into it because we know, with one thing we know for sure after sort of playing in this world, is that everybody's experience and journey is different. I mean, some things are the same, but there's a lot that's different. And then the time and the age that all of this happens is different. But before I do that, I just want to give you a proper introduction and welcome. So everybody, this is Dr. Stephanie Culver. She's a board certified OBGYN, and she is a Menopause Society certified practitioner. And the Menopause Society is the new name of NAMS, which I think a lot of you, if you're in this world, know. So that was the North American Menopause Society. They just had a rebrand. And she is a fellow in the American College of Obstetricians and Gynecologists. That's a big, long thing to get out. And she is a staff physician and menopause expert at Pandia Health. And Pandia Health is a telehealth company, female founded, which we love, and female founded by a female, or female founded, female doctor led, which is really rare in many, many businesses. So we love that, all females all the time. And they are about to launch a whole new program to support programs and services to support menopause. And so Dr. Culver is going to tell us all about that. But without further ado, welcome to the Midlife Conversation with us, and thanks for being here. And so let's dig in. Let's get into all things menopause. So Lizzie and I were just talking a little bit about sort of our own symptoms from peri into menopause. And we're both postmenopausal, so we're proud patch wearers. Right? Lizzie and I were joking yesterday. Lizzie said, she's like, if it became a choice between my husband and my patch, I would choose my hormone patch and send my husband packing.
Exactly.
So,
exactly. And I stand by that.
Stand by it. Sorry, husband. So let's start with the most basic question. What are the symptoms of perimenopause and menopause, and what age do they begin?
Mm-hmm. Yeah, that is a great question, because normally women in their 40s are very busy. They've got a lot of responsibilities. Until fairly recently, we didn't have a lot of data or education out there to let women know that a lot of symptoms begin in their 40s. So perimenopause is really somewhere between, it could be in your 40s, it could be your late 30s, that you start to have symptoms. And those symptoms are just a result of, your body, your ovaries and your brain signaling each other, ovarian function, and we're all different, we're all unique. So our bodies are different, but the symptoms of perimenopause can be subtle and they can be dismissed easily. But some of the ones that, I was surprised to learn about were like the dry eyes, of course, the dry skin that you start to notice. A lot of women complain about just feeling more anxious. It's not PMS, but it's an undertone of more anxiety. And we start to dismiss that because we're so busy, and we think, well, is this just because I'm more concerned or more worried? But it starts to interfere in our relationships and our lives. Then sleep disturbances. You don't necessarily have to have hot flashes to have awakenings at night, and that has been shown to be fluctuations of estrogen. So hot flashes, night sweats, palpitations. Some women describe that all of a sudden they just feel like their heart is racing. And of course, we're going to take those seriously and go for help and guidance. But that is also a symptom, is palpitations. So there's a whole gamut, because estrogen works on all of our organs. We have estrogen receptors all over our bodies, and we need to listen to women when they talk about something that has presented
I was
for
just
the
going to
first
say,
time,
it's funny because now that
and really listen.
I'm postmenopausal, Jen and I were talking about this, is that, it's in the rear view mirror. A lot of the things that we navigated are through the rear view mirror. But I get, my younger sisters, I have friends that are calling and texting saying, hey, what do I do? How do I treat this? Where do I begin? And there's so much misinformation, once you start hitting Google. What are the, just the bare bone basics? Where does one begin as far as treatment? When they go to their doctor, what should they be saying? Because I got an earful from my sister, and I went, whoa, 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 time out. What would you advise someone, Dr. Culver?
You know what I would do? I really like our resource, the Menopause Society. They have all the experts there that have compiled the guidelines, our statements. They have a section for women to look and Google on their own, but they also have a questionnaire. So you can go through some of this material before you take it into your doctor. And that's really the important thing, is to actually pre-educate yourself. So when you go into the doctor's office, you know the most concerning points that you want to talk about. And then you also are educated on, geez, I really need to stress my family history and make sure that I've talked about someone in my family dying before the age of 50 of heart disease, or my cancer history and so forth, or my family cancer history. So it's really to armor yourself, have the questions already available to ask, have an understanding of what are the interventions or treatments, or even the non-hormonal treatments that are being offered for these. And then you can have a really good conversation that you walk out of the office and there's a plan, rather than still the question mark, or I forgot to mention this, or maybe there's another repeat visit to go over. Some concerns actually take a whole visit, right? Like sexual health, that can be a whole different visit. And we want to make sure we give women permission for that, because that's important too. So in OBGYN, we're responsible for so much to talk about. And that might require more visits, but to really armor yourself when you go in.
Usually at this point, though, when the perimenopause or menopause hits, there's so much shit going on in our lives, and we've got so many balls in the air. It really does require us as women to take responsibility and really double down on getting to the root of our health problems. And I think we're so used to, especially if we're raising kids and have families, is just, give, deal with everybody's problems and issues and appointments and getting them to point A and point B, that we're on the back burner. And so we do want, I know I was guilty of them. Like, oh, I just want the quick fix. Like, I got stuff to do. I got things to do. I'm a busy person. And the reality is we can't really do that with this stage of life.
Correct. And this is why even before the pandemic, Pandia Health was in the telehealth space on reproductive health. And we do know that oral contraceptives have been a tool for a lot of women, even in perimenopause, to deal with heavy menstruation, hot flashes even, and so forth. But telehealth has really been a very positive place for women to get immediate solutions for very obvious symptoms. So we know that FDA has approved hormone or menopause hormone treatment for hot flashes and night sweats, and of course severe GSM, which is genitourinary syndrome of menopause. So right off the bat, you're really taking care of quite a few people that then have the relief and get the sleep, are able to cope, and then are able to carve out maybe 10 or 15 minutes to then say, okay, what else now do I need to do and address? Like, what's the next step I need to do? So that's one way to get the foot in the door and then really open it to go through it and make some real critical changes we try to get women in that perimenopause, menopause transition period, because that is the time of vulnerability and the time where we can really make an impact on our future health.
One thing I know,
of
after
course,
talking for so many women,
as well.
because you know, I have a podcast, Lizzie has a podcast, so this conversation comes up a lot. And even if I'm not talking about menopause, we're just talking to women in, you know, in leadership, women running homes. We're all, like Lizzie said, we're all doing so much. And two things that pop up are the inability to sort of function at the same level that we are used to functioning, and maybe more like multitasking, because I know enough to know that our brains are actually really primed, and we're really in a really great spot to you know, tackle like that big business idea or to go do a passion project. But that ability to sort of multitask and focus, I think it's that brain fog. And there's all that all these articles that have come out now that it's really impacting women in work, and that women are leaving the workforce in droves because there isn't any support with their companies. So, I mean, what are you seeing with that? I mean, I would love to see menopause support in every single company out there, because it's as important as any, you know, it's the next journey in women's health.
Absolutely. And I mean, for the most part, I think sleep is one of the most important aspects of our health. And we know that that is disrupted in a lot of perimenopause and menopause women. So tackling sleep, whether or not it's menopause hormone therapy or just oral progesterone, can really help and guide. And of course, there's other things such as magnesium supplement that can help with sleep. But addressing sleep, which therefore has a positive impact on mood. And we do know that when menopause hormone therapy is given, there have been studies that show that women's moods improve. And even if they're on antidepressants, perhaps they don't need as much antidepressant. So there is a correlation, a positive correlation between addressing your hot flashes and sleep and mood and using menopause hormone therapy. But into the workplace, if we're feeling like we can cope, perhaps that can help. But education in the workplace, of course, having more women involved in leadership positions, having women bosses, more women around you. There's also the whole buy-in on women need to support each other. And I think we're really understanding that women are supporting each other, but there's also women that don't realize that they're in the fabric and the network of still the patriarchy and how it's functioning. And we just have to help women see it, extract ourselves from it, and really, you know, be collaborative. And that's a point that I'm hoping we're moving in the direction. I know that there's some noise up in DC where they're trying to get maybe some menopause legislation up there. I know in the UK, they've been talking about it in their parliament, and I think they've done some legislation, but I think that's definitely ongoing. And I know that the Menopause Society and some of its members are working on that right now.
We're talking about menopause and going back to symptoms and your doctors and your treatments, and even, you know, Pandia Health can help these women through telehealth. Go through, if you could, the treatments, because that's what you hear a lot of misinformation about. I mean, you hear identical hormones, bioidentical hormones, pellets, progesterone, tea. I mean, it's just like boom, 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 boom. And if you're just coming into this, it's a lot. So how would you break it down for women?
Well, breaking it down is really looking at your symptoms and then looking at your menstrual cycle as a vital sign. So based on straw classifications, we can decide scientifically, are you in late perimenopause, or are you transitioning, or are you in menopause? Because then that can guide treatment plans. So if you're early perimenopause or still having regular menstruations and you're having symptoms, and these are symptoms that can be varied, but symptoms that you discuss online or in the office, a birth control pill generally is strong enough to control the menstruation, and therefore, because you are menstruating, so your body's seeing like higher doses of physiologic estrogen. So oral contraceptives are a wonderful intervention and a good tool. Then if you're transitioning and you have fairly infrequent menstruation, but you're also concerned about contraception, there's another aspect to this, which is becoming more popular, is using the progestin IUD, which delivers progestin and locally to your endometrium, takes care of contraception, takes care of painful periods, menstruation, and then you can mitigate your symptoms through transdermal or oral estrogen. And that's sort of what I tried to do for the late perimenopause that have fairly infrequent menses. Tried to get them on either they want to do the Mirena IUD, or I give menopause hormone therapy sequentially, which means I give 14 days of progesterone orally along with the estradiol patch. And therefore, it helps to schedule and not have so much unexpected spotting or bleeding when you initially start. And most women actually don't have irregular bleeding or spotting. It can be a common side effect, but most women are not coming back for that. And then women who have already transitioned and has been a year since their menstruation, then you can go directly to oral nightly progesterone along with estradiol, the pill or the patch, or there are other formulations, right? There's the conjugated estrogens as well. So we do have different types, but they all really they're all FDA approved for the symptoms, such as the hot flashes, the night sweats, the prevention of osteoporosis in menopause women, and of course to address genital urinary syndrome of menopause. There are other, of course, symptoms that we use menopause hormone therapy for, and that is more of a discussion, of course, on are we going to use this? This is a very reasonable approach to address your moods. This is a very reasonable approach to address your joint pain or your libido or your fatigue and so forth. So these are more complex discussions, and certainly women are turning towards menopause hormone therapy to address that. But of course, there are the position statement just recently by Menopause Society talking about the non-hormonal approaches to vasomotor symptoms. And of course, there are people that still want to use lifestyle to address their menopause symptoms. But to those individuals who really believe they want to do things naturally, I just heard recently someone I really like that talks, she's an expert in her field, Dr. Casperson. And, you wouldn't do something naturally, like you wouldn't necessarily go through something naturally like a surgery or heart disease. You're going to want treatment. If someone says your cholesterol is out of control, you would take that medication. So don't, shy away from something that our body actually has produced. We produce it, so it shouldn't be something that we should be fearful of. But of course, to have a discussion and to make sure that you're taking it for the reasons that you want to.
A couple things just popped up. First of all, we know Dr. Millie Jefferson, so we both smiled when you said that. She's fabulous, and she's doing such important work out there. And the second thing is that we know a lot of women that can't take hormones just because they've had cancer, and so it's just not an option. So do these natural options help? Well, are there the natural options that actually do help with sleep and all the other symptoms we talked about?
Yeah. So there's non-hormonal approaches, and so there's lifestyle, and then there's mind and body, and they just recently, Menopause Society just recently set out a guideline, and women can go onto that site and print it out for themselves. But it turned out that hypnosis, as well as cognitive behavioral therapy, was helpful. And that was shown by studies, statistically significant, to work for vasomotor symptoms. And then in terms of medications that are non-hormonal that work for vasomotor symptoms, there's paroxetine, which is a low-dose SSRI. And then there's Vazoa, which is the new medication that works centrally. And then there's others like gabapentin. But I would say most people will go on, paroxetine is fairly common, and Vazoa is like the new medication. And so for women that have cancer or are being treated for cancer,
You're talking about
these are options.
Estrogen here, and I think one of the things that I know I've experienced is dryness, and vaginal estrogen is something that's brought up, that some women are like, why do I need that? I take a pill, I take a patch, I put something in my vagina. Can you elaborate on the purpose of vaginal estrogen?
Yes. Well, we have like very strong advocates out there on Instagram and social media. So it's wonderful to have like a whole army talking about vaginal estrogen, because it really, there's very few restrictions on taking it. And genital urinary syndrome of menopause is a chronic condition. It doesn't just go away. And so it just will worsen as we age. And vaginal estrogen can be started in the perimenopause period. And there are some birth control users that have vaginal dryness because of the increased blood levels of a globulin that kind of, takes testosterone out of our bloodstream. We like it for our face and acne, but it help with libido. And we do have androgen receptors in the vagina as well. So we do know that androgens can be helpful, but vaginal estrogen can help estrogenize the vaginal mucosa and also the uroepithelium. So therefore you will have maybe less urgency, less kind of incontinence issues. Not everything can be solved with vaginal estrogen, but it surely helps with sexual function. It can help with sexual arousal, sexual sensitivity, and therefore it's very important to bring this up and to give women permission and say, hey, have you considered, vaginal estrogen? I don't see this on your medication list. Because as women get older, there are urologic studies that demonstrate that women that are older can have life-threatening UTIs. And we do know that estrogenization of the vagina can improve our vaginal microbiome with, what microbiomes we have and so forth, and what the balance. And if we have an off balance, then we can have more infections, and that can be life-threatening as we age. Also for OBGYNs that have examined a lot of women that are older, it's hard to do examinations. So you're basically making it harder for yourself to have a full comprehensive examination as well.
Those who've had cancer or who kind of just don't want to maybe go more natural is what we were talking about.
Yes, I think that these things are the guidelines are such that for the majority of cancer patients or cancer survivors, yes, there are some there are some risk benefits to talk about, such as, you know, did you have, what stage was the uterine cancer, or what stage was, you know, if there was a vaginal cancer, or was there a leiomyosarcoma? I mean, there are certain instances where you know your history and you sit down or you discuss this by telehealth and you do literature searches and you look, and in connection with your oncologist, you can make a plan and move forward if that's reasonable. But for the mostly, yes, there are a lot of women that have had breast cancer or breast cancer survivors that take vaginal estrogen. But again, that is, you know, we have to know what the history is. We want to acknowledge the history. And then there's also quite a few oncologists that are on board or getting on board with discussing this before women's treatments or during their treatments, so they don't suffer and come when they're already experiencing these issues, because they're already dealing with enough issues. And so how do we get the education to women and their treating doctors that this
I
can be
had
a
my
safe
followers ask
intervention?
questions, and one of them asked, "What is wrong with just continuing on with birth control?"
Yeah. Well, birth control is a higher dose. It's a different estrogen, has more potency. So as you age, your risk for cardiovascular events will increase. So it is, according to guidelines and according to recommendations, generally we're going to switch women from their birth control onto menopause hormone therapy if they choose. By 52 to 53 years of age. Of course, it's all different for women. The mother of a woman, like the maternal history, is actually the strongest predictor for when a woman will enter menopause. So if a woman says, well, my mom was menstruating till 56 years of age, we can have a conversation about, when transition is. But if there is a question, a woman can stop her birth control. This is the one time where OBGYNs are all like, yay, we can do a lab test. We'll check an FSH or an estradiol and see where you are on the continuum. It's a snapshot, but if there's just a super high FSH level, then we can assume that you've transitioned. And if you'd like, let's move on over to menopause hormone therapy. I tend to think that that's a good idea because we do lose a fair amount of bone within the first 5 years of transition. So it's a good idea
just
to
made me
stay
think of
on
another
it if
question,
you tolerate it
and that is, say you've entered menopause, it's been a year since your last period. If you didn't start hormone therapy right away, is there sort of a window of time that is ideal to start?
Yes. And that, in general, it's within 60 years of age or within 10 years of your last menstrual period. So either one. So if you're 60 but had your last menstrual period 5 years back, you're still within that window. And that window was created because looking across the board, cardiovascular wise, where would we have our limit in terms of like, when is it the threshold for risk benefit? Obviously, there are women that are taking it and do start that are outside that guideline, but we counsel and say, listen, you're starting older than this critical window, this window that we like to start women in. So we're going to recommend the transdermal patch because that is thought to mitigate the risks, the cardiovascular risks. But again, it's an individual choice. It's a discussion on what exactly is it that's debilitating. Surely hot flashes and women can come and be just at their end, like their wit's end. And so we certainly need to listen to that, and we need to allow patients advocacy and of course to make the ultimate decision for themselves.
Women think like, I've changed my lifestyle, I've stopped drinking, and I'm eating better, and I'm doing all these things. There's nothing, that no one can help me. I've done it all. What do you tell those women? Right. They're not using any type of treatment.
And they're not taking. Yeah.
I mean, I think it varies.
Yeah, but what are their symptoms?
Anxiety, sleeplessness. Some of the hot flashes are still prevalent.
Yeah. Yes. So whenever there is the FDA approved, like I have hot flashes, I have night sweats, then I'd say try it. It doesn't mean you have to stay with it if you don't like it or it didn't work for you, but you can try a low dose and see if you sleep, because and see if your hot flashes dissipate, because we do know for the most part, been doing this long enough, people respond fairly quickly if it works. And it generally does. It's the most effective treatment. And that's what I would recommend. And if they don't have anything to restrict them from taking it.
I was like, what I do and what you do are going to be two different things, and that you might need a tweak here, or your doctor might need a tweak there. Like, everybody's got a different body, so it's going to be different dosages for everyone, right? So getting there may take a little time.
Yeah, I think that people do need adjustments, but for the most part, I find that people generally do all right with the standard
It's dose.
Great
to know, because I feel like with a lot of us, it's kind of like grin and bear it, suffer, trudge on through. And I just know, we're so vocal about all of this, that the conversations I have, we all have all these conversations. And I feel like there's still so much, it's kind of like shame or embarrassment around saying that you're in menopause, because women are dealing with weight gain and body changes. I remember, I was in yoga 2 weeks ago. My yoga teacher was like, "Hey, Jen, did you get a boob job?" I'm like, "No, that's menopause." my body reshifted. So I'm like, I guess it could be worse, but but it's still a change. And so I think, with that, and, if there's brain fog and people have anxiety, and like Lizzie said before, and most of us have kids that we're launching and careers. And so there's just all this stuff. And women have not been talking about menopause openly. They just haven't. And even like, we're all in this world, so we feel like we talk about it, but we know, because as soon as you step out of this little menopause world, everyone's like, help, or I don't know where to go. And these are, and we're all speaking from the Bay Area, where we have like world-class the top, medical facilities and doctors in the world. And there's still like lack of information and confusion. So this is leading to a question, and that is, for women watching, because women are going to be watching this all across the country and across the world, but we'll focus on the United States because that's where we are, that we know that a couple things, that one, most doctors aren't trained and don't get a lot of training in menopause. So that's, obviously the Menopause Society is out there to help with that. So, but we've all heard the stories of women going in to speak to their doctors, and they either dismiss or they can't advise. And, we always like to come from a place of partnership. So for all the women listening who are like, I'm not getting the support, or I don't know where to go, and I am suffering, what would you offer to them of how they could have this really rich conversation with their doctor to get the support that they need?
Yeah, that's a great question. So I think a lot of women are going on social media, or they Google, and it's really important to really seek guidance from good resources. And again, Menopause Society has members. You can log in and find a provider. And of course, there's telehealth companies that employ, and they have physicians that are OBGYNs, they're fellow of the American College of OBGYNs, and they're Menopause Society certified practitioners. And therefore, you know that these individuals and these doctors are trained. But you're right. What happens is that we need to be, again, more visible. And I know that there's an army out there that's doing that, where I just went to the meeting, and there was even a discussion that every single certified practitioner should be on social media to counteract, the mistruths or the, unfortunately, there's money to be made in misery, which is horrible. And, there's so much out there that might work for an individual, but really globally, maybe it's not really working for somebody else, or on a large scale. It might work for you, but then somebody comes out and they just want to tell everyone about that, which is good. I mean, everyone's narrative is important, but we do have to keep things in perspective, and that there are observational studies. There are, of course, studies that have shown what works and what's effective. And we do know what is effective for a fair amount of these symptoms. Of course, we still need to do more studies, and we are very far behind in women's health in that respect. In terms of brain health, that's like one of the biggest concerns of mine, is that 2/3 of Alzheimer patients are women. And, nobody really cared about that. And we take care of everyone else. And, you have people like Dr. Mosconi, who's, a leader and writing books. And there's a lot women can do on lifestyle too, with food and exercise, to keep our cardiovascular system healthy as well. So there's a plethora of positive people out there. It's just, we got to get women
one final thing,
to the right sources.
We talk about how we're these master jugglers, oftentimes women, and we're talking to you about, like, what are some real practical, tangible solutions to deal with menopause symptoms. But I would have to say, as I was in the midst of my menopause journey, and I was trying to grit and bear it and get through it, and I was being snappy to everyone, I had a lot of shame. I know Jen mentioned shame, and I didn't want to really go deep or dig deep talking about with my husband, because I was, this career woman and this mom, and what all these crazy expectations I put on myself, that I didn't want him to see me as this old lady all shriveled up, which is the big joke in our house. And once I had that conversation, like, okay, I know we joke around and we throw the menopause word around in our house, and mommy's old and mom's dried up, or whatever. But once we sat my husband down and my kids and just said, hey, this is real. This will happen to you. I have 2 daughters. This will happen to them. And I need your help. I need your compassion and your empathy, and maybe not as many jokes right now. That for me was a huge shift, I think going through this journey was getting my family really to put their arms around me and walk with me as I went through the transition.
Well, I'm really happy to hear that they listened and they did walk with you, because not every woman's experience is like that. And unfortunately, we do know that domestic abuse and emotional abuse is high, can increase during this period of time, because women are questioning their symptoms, and they're questioning some of their brain fog. And it can be exacerbated by someone not being as kind as they should be. So it is really imperative that we have these discussions and how to teach men to look at this. But really, I think it comes down to, if a man is a good partner, he's going to be a good listener. And I think it just means that if you found yourself a good partner, sit him down or sit her down and have that discussion. Because if they're listening, they'll be empathetic. And there are women, of course, that have found out that they have other plans in their life when they go through menopause. And that can be very liberating too, where we find out and we look inward because we've gone through a struggle and we've really evaluated ourselves because we went through it. And it's a time of reflection, and it can be very liberating to not have to worry about, you know, our menses or pregnancy. I think also our brain is, women's brains are so fascinating in that I think we naturally tend to not care about things that don't need to be cared for. And there's a real potential. And that's what's really exciting about menopause, is that we have the energy. We're strong as women. Our brains are plastic. We've got to keep up with our health and really live a good life. And that's why it's so important to talk about the medical interventions, the health interventions, because there are real solutions to allow us to enjoy this part of our life.
I love this. Is such
It's
a
very
beautiful
fun
way
and
to
very
end.
exciting.
And Lizzie, I'm so glad you brought that up because I too had I can't take the mom's going crazy comment one more time. I did have that conversation. I sat down and most, you know, however you all are partnered up, most men, they don't intuit anything. You've got to tell them. They're not just going to know, oh gosh, she's going through the change. They don't know. They have no freaking clue. So I'm so glad you brought that up. And I'm so glad you brought up Dr. Culver, just this ending on this positive note, because we've seen this too, and we talk about this a lot, how this menopause it's an ending of kind of one thing, but it's also a beginning of a new thing. And I just think I remember a doctor told me way back when, she's like, Jen, getting stabilized and doing all the things you can do, you know, health-wise, taking care of yourself, looking at support and therapies, medical and otherwise, when you get to the other side, she's like, it's amazing. And so I held on to that. When I was like, especially going through perimenopause. And so there is. And so we've talked about that ad nauseum. So I love like ending on this high note that with the right support, lifestyle, enrolling all your people and what you're going through. And of course, we talk a lot about community and girlfriends and relationships. So that's really important too, that, you know, let's talk about this. Let's demystify. There's no shame. It's a beautiful place to be. We're all lucky enough to be alive and to go through this, and that let's just end this on a high note. It's all, there's nothing but up. There's nothing but up, in my opinion. So one of our final questions for you is just tell us a little bit about what Pandia Health is offering, because I know you guys are going to be launching your menopause services soon. So we definitely want to know about that. And then we're going to wrap it up and let you go.
Yes. Great. Well, I'm excited for this because Pandia Health has in the last several years been giving reproductive healthcare guidance and help and medication. And women use birth control pills for various different reasons, for contraception, but also for lifestyle, for periods optional, and so forth. And we see a lot of women in their late 30s and 40s. So it's just so natural to help women on this journey. It's a continuum. So Pandia Health is going to launch the second part of their outreach, right? Which would be menopause or perimenopause and the transition and supporting women with medical interventions.
It's exciting.
It's fantastic.
For their symptoms. So, yeah. And of course, there'll be education as well. Education, and there will be advocacy. If we know Dr. Jen, there'll be advocacy involved in it, and layers, and outreach, and making sure that there's access for women. And that's another big one, right? It's access. Like you mentioned, that a lot of doctors aren't trained in menopause, but there's also the access issue. There are women that don't have health insurance, and there's all kinds of other barriers, but online and telehealth seems to
That's
help
fantastic.
diminish those
Love it.
barriers. So super
So
excited
I've
about
linked
this.
in my
Yeah.
link tree in my link in bio. Everyone, if you're watching this in the replay, you can go to the link in my bio, and the first link there is Pandia Health. So you can find out more information about them there and get on their waiting list for menopause. It's not officially launched, but it's going to be any day now. So that's very exciting. And so, Dr. Culver, just tell everybody where they can find you and find out more information about you and follow you and get more of your fabulous advice.
Oh yeah, thank you. Oh, great. Yes. So I'm Dr. Stephanie Culver on Instagram. And then of course, Pandia Health. So both of those, you can find me on my personal Instagram. So I do post a lot of things menopausal, perimenopausal, and a lot of things about mothering, because I have 5 children. 5 children. So I have 2 in high school still. One is senior, one a freshman. So I think I can
Love
speak
it.
from a lot of different
Thank
So
you
we're
hats.
so
gonna
much,
link all
Dr.
that.
Yeah, wear a lot of
below.
different hats.
Sorry, Lizzie, I didn't mean to talk over you. We'll have all the links and all the people to follow down below in the notes if you're watching this on the replay. But thank you so much for sharing all this knowledge, because again, we know we talk about it. Lizzie and I
You're
were like,
welcome.
it's Menopause Awareness Month. We've got to
Yeah.
dedicate today, like the kickoff, the first week of this month, and talk about our health, because it's so important. So thank you. We just really appreciate you spending time with us today.
Thank you.
All right, ladies, have a
Thank
beautiful
you.
day.
Nice to
Bye.
see
Bye-bye.
you.
Bye.
Bye-bye.